Thank you so much. One thing that we didn't add, because it only happened in the last week, with our accreditation, so we have probably the highest standard, only 3% of museums are accredited. Took us 20 years of work, you guys can appreciate that, and 2 years of review, you can appreciate that. Because of our accreditation, 2 weeks ago, we received a $250,000 grant to improve our storage. So why do you want to be accredited? Because you get the top grants and monies because you do the good work. So we are actually getting 30% more of our space in the existing area with movable stacks, and they're quite expensive. The thing about that is osteopathic healthcare is continuing to grow with 66 teaching sites, 10 more in the pipeline to come. Already 25% of medical students are basically osteopathic focused in philosophy. So we probably will be up to about 33% in maybe another 4 or 5 years. So it's an amazing, from one person, Andrew Taylor Still, 150 years ago, this is our anniversary of the discovery of osteopathic healthcare. One person, today, 25% of the medical student profession, so we're in a great area. Again, I'm happy to have Jonah. We have amazing students coming out of the founding school, and you'll meet several of them here. And let's move on with our program, because it's kind of fascinating, all these little details, as you realize, it's the little stuff that matters, that have created where we are today and why you should be proud of your osteopathic anesthesiology background. I have to do our disclosure. We're not making any money. We're not selling anything. We're just giving you a good story and a good time to have a little entertainment here. Again, going through the AOCA. Again, our disclosure forms. I think our learning objectives will be kind of fun today. We're going to see Dr. Still's ideas of understanding the need for surgery. You know, we always think of the manual medicine as part of osteopathic healthcare, and that was true. But he says that surgery is needed, but it should be done as the last resort, not as the first resort. And so hence he understood the need, but he also understood timing with that need. We're going to have a review of anesthesiology and surgery founders. Jonah will present that with Dr. James Young Simpson and Dr. Joseph Lister, who had major roles in surgery, and we'll kind of review those a little bit. We'll have examples and historical facts about the profession's founder, Dr. Still, and his understanding of pain reduction and hygiene, and the importance of it. And this will identify the work of the American School of Osteopathy and the faculty that really put anesthesiology and surgery on the right path. So that is why we are here today, 150 years later. So Dr. Still would tell us that in order to understand something, we have to get before it. We have to go back when it didn't exist and then move forward. So we're going to go on 2 tracks today. We're going to kind of look at where anesthesiology came from, which obviously not in frontier America. That was happening in Europe, which had institutions for thousands of years in medicine and discovery and research. So we're going to be looking at how that came into influencing the Midwest and where we are today. Any piece of this story could have gone one way and the whole thing would have toppled like a house of cards. So I think it's fascinating how lucky we all here to be in this profession, and you're going to see all the little pieces that came together and made it work. So we know that from Dr. Still's study of the human body, again, he analyzed and looked and did anatomy, and what he came to the conclusion of as biological systems, that what comes into our body, nutrition, and the natural flow of blood, looking at Virchow and some of the Germans that were discovering cell theory. And so understanding basically the biological system of nutrition in and waste out. But anyway, understanding how that works kind of threw me off just a little bit. But Dr. Still had understood the biological system where everything is connected and how things work together. Any disruption would lead to basically disease and basically ill health. And so Dr. Still was achieving health and a focus of the whole person, body, mind, and spirit. And we look at that even today a little bit. We know the physical body of anatomy, but kind of what you do is very spiritual as an aspect. When we look at what's going on under anesthesia, the vibrations, the microtubules that are turned off. We're starting to look at quantum physics. What is the disruptions that are going on that cause this to work? And of course, it's still a very young field of figuring out how this works. And so Dr. Still understood how this connection of this spiritual energy vibration works within this physical body and completes the system. He found that manual medicine was very effective, but that also surgery would be needed as a last resort, and promoted that extensively. So just in his own word, osteopathy is not a drugless therapy, that he understood that there were antiseptics, that there are parasitics and antidotes and anesthetics and narcotics for the removal of pain that were needed in patient care. He also felt that the osteopath should remember that sensible surgery is part of osteopathy. And if you do due diligence, you'll know when surgery is needed and when it could be prevented. And last but not least, he established a school. The object of the Corporation of the American School of Osteopathy, the founding school, is a college that is designed to improve the present system of surgery and obstetrics. Dr. Still was huge in obstetrics. That was one of the better things, the main things that he worked on daily, and probably through anesthesia. Having had 2 children myself, or at least my wife did and I was present, seeing the importance of a spinal tap. And when that window was closing, it's like, open that window up. We're going to need something here. This kid's coming way too fast. And so, again, obstetrics, Dr. Still was very focused on reducing the pain and helping to have healthy births. So in reducing pain, without using anesthesia or narcotics, Dr. Still had such an understanding of anatomy that he could literally touch portions of the body and lower a fever or open up or close basically the colon for diarrhea to stop it or to flush the system. He was able to work the body like an orchestra, turning things on and off at his pleasure. Normally the body works pretty well, but the body makes mistakes. For instance, if you injure yourself or get a cut, you might get a swelling to immobilize the area. But immobilization keeps the current flow, the rule of the artery, blood, nutrition coming in, cleaning coming in. That stops, gangrene could set in, blood poisoning. Dr. Still could actually reduce swelling so the body would do what it needs to do to heal. So he understood that we would intervene when nature sometimes misunderstands what's going on and might kill you. And so this is kind of the cool thing, that Dr. Still could touch and work with a variety of systems. And so here we see actually, Dr. Still tells the story. So what Dr. Still describes as, that's where we need to be. So what Dr. Still describes as a story of the first type of nerve blocking or pain reduction is that a young man had come to the dentist, and he was present to see this. Extracting the tooth, the young man was squalling, crying in great pain, and left basically the dentist screaming and crying. And what we discovered was that So what we discovered was, with this squalling and crying, if you were in the dentist's office, would you want to be the next patient? Definitely not. And Dr. Still told the dentist, we can minimize the pain if you want to see. And so the next patient was a young woman, and Dr. Still was able to block the nerve and the feeling of pain. And what ended up happening was basically the tooth was extracted, and the woman didn't even know that she'd had the tooth removed. And that's where we should be. So in this diagram, we have thousands of pages of Dr. Still's notes. And Dr. Still diagrammed for himself how to keep the patient silent and do dental therapeutics. Unfortunately, you can see the teeth, you can see the tongue, but we don't know a lot, because this was Dr. Still's little note to himself of what he needed to explain later. But we do understand that Dr. Still had this understanding of how this would work. And again, Dr. Still identified that in his, after he had started the school, his first book would be on obstetrics, because it was so important and so needed. And so we see here where that is at. So at this point, I'm going to turn it over to Jonah. Hopefully he'll have more luck working on his section of the program.
Thank you, Jason. So I'm going to talk about a few individuals, doctors I suppose, who were vital to the creation of anesthesia as a field. So first off, Sir James Young Simpson. You guys might know of him because he discovered chloroform. He was born in a Scottish village to a family without a lot of means. His family pulled together their money. They were able to get him to Edinburgh University at only 14 years old. Simpson would struggle a lot emotionally following the death of his father, but intellectually he was very bright. Everyone could see it. And so at 18 years old, he would pass his boards. He passed his exams at College of Surgeons and immediately began his study of obstetrics. By October of that year, he was appointed assistant to the director of the dispensary, which was quite an honor, I'm sure, especially at that age. In the following years, Simpson would go on to tour many of the leading medical schools in England, in France, and in Belgium. He went with his mentor, John Thompson. I suppose this kind of shows the importance of having a mentor who really kind of stands with you and helps you on that path, because he was a little bit burnt out, it seems. He was intellectually very bright, but just struggling and getting to see all these different medical schools, getting to learn, and kind of like reignite that passion is believed to have kind of, I suppose, propelled Dr. Simpson into his next phase. Okay, and then seen here is, I believe I've already mentioned it, but there is a College of Surgeons in Edinburgh, which is going to be very important to this story. Jason's going to talk about it as well, but yeah, it's very interesting. It was a powerhouse, effectively at the time, and the fact that it had so many ties eventually to Kirksville College of Osteopathic Medicine, interesting, just kind of for where we started, particularly with ties to anesthesia. Anyhow, Simpson then would establish his own private practice in general medicine, obstetrics. Particularly in obstetrics, I think people realized this kid's really good. And so he gradually would have wealthier people who wanted him to look after them, eventually including nobility. However, Simpson, he wanted more. I think he wanted to create something, and he was really interested in anesthesia. At the time, they would use ether. Not quite there yet. Yeah, we'll get there in a sec. At the time, they'd use ether to decrease sensation. He used it in a complicated labor, and he realized that this was helpful, but he thought there was something missing. He thought, we can find a drug that is a lot better than this. Spoiler, that was true. And so Simpson, alongside his assistants, George Skeen Keith and James Matthews Duncan, they began a search for a new form of anesthetic. They tested many compounds before finally finding chloroform. You can see them making this brilliant discovery in that image. Upon handling the sample, they fell to the ground, which still does occur with chloroform. By November of that year, less than 10 months after his initial trial with ether, Simpson made an announcement of a new anesthetic agent. He would use chloroform in obstetrics for the first time on November 8th, 1847, and chloroform then became the anesthetic of choice. Eventually there were issues with supply chains and adverse effects, but Simpson still believed to be the first to use chloroform as an anesthetic. All right, here is Simpson, significantly older than you last seen him. He would go on to win a variety of awards. He was appointed physician to the Queen in Scotland, physician to Edinburgh Royal Infirmary, and president of the Royal College of Physicians of Edinburgh. On April 7th, 1853, Queen Victoria would give birth to her 8th child using chloroform. This silenced a lot of the opposition that Simpson was experiencing. He was then awarded honorary membership of the most distinguished medical societies in Europe and America. All right, we're just going to keep fighting this a little bit. I'm going to pass it back to Jason to talk about Louis Pasteur.
And so, as we're familiar with, Louis Pasteur was one of the first persons to understand how there were microorganisms, systems that all worked in complexes. And Dr. Still also promoted this in our curriculum, that we would also follow kind of the research and stuff of basically Louis Pasteur, and he wrote extensively about it, how any type of stagnation and lack of circulation, lack of cleaning, as we discussed, like in a swelled area where there cannot be circulation and cleaning, that's when disease and fermentation would begin. And so this information, again, was very much part of what we were understanding and teaching through Dr. Still's basically curriculum at the school.
Thank you, Jason. Now another famous Scottish doctor, Dr. Joseph Lister. Louis Pasteur's experiments, a lot of which, people don't know this, were on like wine or on beer. It's kind of the idea of where, fermentation, a lot of that came from. But Lister was a surgeon, and so he was able to use his experience with the microscope, his understanding of coagulation, inflammation, and this allowed him to see what the opportunity that Louis Pasteur's research showed. So he would promote the idea of sterile portable ports while working at Glasgow Royal Infirmary. He would utilize carbolic acid, which is now known as phenol, to sterilize surgical instruments. One thing that's funny is Lister believed, which was a very reasonable belief, that germs and bacteria and everything was traveled just through the air, which we know is now not entirely true. But the good thing about if you're trying to stop infection from spreading through the air is you're also stopping the spread from hands, surgical instruments, pretty much everything that I suppose you all are concerned about right now in your practice. Lister's work was largely misunderstood in England. There was opposition against his germ theory more than against carbolic treatment. I don't think many people believed it was dangerous. They maybe just didn't believe germ theory existed and thought it was not a good use of resources. He would kind of change people's minds with a few operations, but one in particular was the wiring of a fractured patella. This was very important because at the time, a fractured patella, minimal risk to patient life, minimal risk to infection. By choosing to have that operation, by choosing to wire it, you're pretty much opening up theoretical can of worms. Like, you could cause a lot of different issues. But he chose to do that with antisepsis by using carbolic acid, and he got amazing results. And I think, people understand that word got out, and when people started to see how well his outcomes were while using sterile technique and using carbolic acid, it really changed the opinion of the time, and this really shaped, I suppose, anesthesia as a field. And then we have one final physician I'm going to tell you about, and then I'll pass it back to Jason. This is a fun one. This is Dr. Joseph Bell. He also is at the Royal College of Physicians and Surgeons in Edinburgh, and he belonged to an Edinburgh surgical dynasty. His father, his grandfather, everyone before him, a lot of very impressive, well-renowned surgeons. Bell was he was an instructor for William Smith, who is going to be a very major part in the creation of osteopathy, and Jason will talk about as well. But a fun fact about Bell is he also was an instructor to Sir Arthur Conan Doyle, and he's believed to be the model that Conan Doyle based Sherlock Holmes off of. So that's just kind of a fun fact. He had like powers of deduction. He was incredibly detail-oriented, and this, I think, kind of set the stage for having a incredibly impressive, detail-oriented focus, including on anesthesia, as he was an early champion of Lister's carbolic spray. Thank you.
Thanks so much. So now we're going to see where Europe and the Midwest collide through William Smith. And so getting back to the United States, here we are in rural America. Medicine, half your patients die. And really, it doesn't take but 6 months to become a physician, mostly bleeding, poisoning, burning, popping blisters, and dosing with arsenic, cyanide, mercury. And if none of those work, just give them enough morphine and alcohol that they think they're okay. So Dr. Still is very successful with his focus on nutrition, diet, exercise, mental health, and manual medicine. Patients are living. He's getting so many patients, hundreds a day. Imagine if it was your child that had the injury or your spouse, you would do anything to get the only person to treat them. Dr. Still was completely overwhelmed, and so he really didn't want to start a school, but he saw no alternative except to train other people to relieve basically the backlog of patients in need that he was getting no rest. And so he starts this little school. He introduces 4 or 5 of America's doctors, but quickly he realizes it's a fiasco. These American physicians with their 6 months of training are worthless, that it is not going to work. And so he actually thinks, I'll just go back to my private practice, and this was just a bad idea. Except that, lo and behold, William Smith pops into the picture. So here's this guy from the Royal College of Surgery in Edinburgh, trained by some of the best doctors and the best techniques of the time. He gets married, comes to America. He's going throughout the United States selling medical instruments. And so this is what puts William Smith in our kind of our focus. He basically is credited, you probably might have even never heard of William Smith, but he is really the linch key that makes this all work. Is he actually stood in the shadows, and with his credibility of 7 years of the best education, gave Dr. Still credibility. And so maybe Dr. Still discovered osteopathy, but William Smith, and A.T. Still had a nickname for him, Bill, and A.T. Still went by Drew, not Andrew, that it was he who discovered basically A.T. Still and brought him forthright so that these ideas could really have success. Now, remember those 3 students in that picture that looked like probably after an all-nighter for medical school? Well, basically, we talk about George Keith. He comes into the picture as very important to William Smith's life. So William Smith, his family is actually, these Scottish people are living generations in Jamaica. His dad's an engineer, builds railroads, has 9 children. At the age of 3, William Smith's mother dies. Well, with all these kids, his father can't handle it. So he's got a couple sisters that aren't married back in Scotland. So he sends some of the kids there to be raised. So William Smith grows up without a father figure. But George Keith is his family physician and mentors him. And so William Smith grows up wanting to be, like his father figure, George Keith, a doctor, and go to the Royal School of Surgery in Edinburgh. About 1880, as a young man, he goes to this school, and that's when Keith kind of retires. He's kind of tired of the drugs and the way the system is, and he actually wants to go back and actually be more like Dr. Still. He wants to look at, basically outside life, fresh air, good nutrition, hot water, cleanliness, and rest. These things give the body the natural ability to heal. So we can start to understand why William Smith, who eventually meets Dr. Still, becomes attracted to his methods. And so basically, William Smith gets married and comes to America. But I should back up one bit. Before then, his mentor then is, again, Joseph Bell, the famous Sherlock Holmes. And so Joseph Bell's, because of the power of deduction, which is exactly what Andrew Taylor Still is, Drew, he's looking and seeing and observing and making connections. And so this is a natural kind of fellowship for William Smith to find in A.T. Still the same 2 leaderships or people that are the most important men in his life. And so we can see from his diplomas in midwifery and basically 7 years of the best education possible, he brings the ideas of chloroform and surgery and obstetrics with his background. He has a state of Missouri license. He easily gets it because he's so educated. So how did they end up connecting? So William Smith, again, he's married, he's in America, he's just selling surgical instruments, making a little money on the side while he's in the States. He keeps hearing in Missouri about this amazing man who's healing cripples and fixing people with chronic headaches and people that are hopeless are living good lives again. He says there's no way this guy on the frontier with no education as far as he's concerned could be doing this. So he comes to town and says, what's going on with this guy? And all the doctors are like, and tells, oh, he's a quack. So he doesn't really fix them. And the doctors say, oh no, he does repair these people. And Smith is like, well, how do you know? He goes, well, we've been his patients. So what does he do? We don't know. So you're a physician, you're a patient, he treats you, and you have no idea what he's doing. This intrigues William Smith. He goes, I want to meet this man. And they tell him, well, don't tell him you're a doctor because he won't see you. But Smith is very honest. He goes to A.T. Still. He says, I'm a physician. I have 7 years of good training. I'm curious about what you're doing. A.T. Still says, I'm way too busy, but I'll give you a half hour. Come back tonight. Half hour turns into 4 hours. Smith is saying, what you're teaching, what you're doing isn't what we learn in school. But A.T. Still says, it's the way it is. 3 months later, William Smith comes back to Kirksville, and now A.T. Still feels that with this quality physician, they can indeed have their school. Smith loves technology. He is already using basically magic lanterns with microscopes to blow up specimens on the wall. He is doing all kinds of things. His understanding of anatomy, he's a lightning drawer. So now we understand what lightning bone setter is. It means you're fast. He's fast at diagramming and explaining, and you can visualize through his lectures what's happening. He's a brilliant instructor. And so basically, we're fortunate. He even uses the first PowerPoints. He has these glass slides that he is actually showing before film is even invented. So again, he uses X-ray machines that they had just been invented. He gets one at the school. He does research in it. So what we find in Smith is a brilliant teacher, researcher, and person of technology. He also brings along then James Littlejohn, who is at the Royal School of Surgery in Glasgow. But these schools work together, Edinburgh and Glasgow, both brilliant school. He becomes head of surgery at A.T. Still University, or the American School of Osteopathy back in its day. So with these two powerhouses from the best school, and even today in Europe, our little school starts off right off the bat with the best. And so what we can see is when they advertise their ability for surgery, they can do complicated, massive surgeries in Kirksville without having to go all the way to the East Coast. So we start to see why we have a foundation in surgery and anesthesiology that no one else has from this time period. It's because our instructors are European. And by the way, William Smith is our first graduate. So our first graduate of osteopathy is actually a Scotsman. So how good was he with anesthesiology? Well, there was a case where Mr. Rice, who from Rice University in Houston, very wealthy man, he's in his 80s and he dies. They think his lawyer somehow had something to do with his death and gave him chloroform. It filled his lungs and that killed him. But Smith, who understands anesthesia, says this is impossible. The fluid you're finding in his lungs is basically the formaldehyde that has been sent through his body to preserve him, and it will go into the lungs because that's how the circulatory system works. And nobody believed it at the time. He says, I've done hundreds of cases of chloroform, and I've witnessed thousands. So his background was impeccable. This was a national case. And he says, this is absolutely impossible. But what they're saying was, let's say that you wanted to kill the person and they were asleep. He goes, you give them a chloroform, they'll wake up immediately. And if you don't do it slowly, there'll be a strangulation and an effect about it. He says, it is impossible that this man was killed with chloroform. And so the case, basically, the lawyer is freed, and it's really one of the first CSI cases of national and international interest. And so what we now see then is how A.T. Still in rural America, with the best of the European schools, through William Smith and James Littlejohn, basically brings this foundation which becomes part of your history and your heritage. And so Dr. Still just said, each of you need to take what you understand and take the profession further. That osteopathic healthcare is never finished, that it is always growing. And as I read in the papers daily about what's going on in anesthesia, it is, your system has so much still yet to learn and so much that you're going to go forward with. Dr. Still would be proud of you and would tell you to dig on.
Thank you for that rich history, deep dive into history of osteopathy. So thank you so much, Mr. Haxton and Mr. Jerabek. Our next speaker is Dr. Dane Grenda. Dr. Dane Grenda earned his bachelor's degree at the University of Michigan and graduated from medical school at the Lake Erie College of Osteopathic Medicine. He completed his residency in anesthesiology at Temple University Hospital in Philadelphia and went on to pursue a fellowship in advanced airway management and head and neck anesthesiology at the University of Michigan. He currently holds the rank of assistant professor in anesthesiology at the Lewis Katz School of Medicine at Temple University Hospital. Dr. Grenda's research interests include novel techniques for non-invasive oxygenation and standardization of difficult airway management. Outside of the operating room, Dr. Grenda is also involved in projects fostering interdepartmental communication and patient safety. Today, he will be speaking on airway management in the setting of difficult airway pathology, subglottic stenosis, and posterior glottic stenosis. Please join me in welcoming Dr. Grenda.
Good morning, everybody, and thanks for being here this morning. I just want to comment on Jonah and Jason. You guys did a phenomenal job with that little game of guess what slides next. That was really good, really good. Again, my name is Dane Grenda. I'm an assistant professor at Temple University Hospital. I'm primarily based out of Fox Chase Cancer Center, so see a lot of complex airway pathology. And I'm going to be speaking on the topic of laryngotracheal stenosis, which I'll further break down for the sake of conversation, posterior glottic stenosis and subglottic stenosis, which in my opinion is the more challenging airway pathology. I frequently speak with some of my colleagues and residents that want to know all the fishing tales and cowboy stories of complex and difficult wake fiber optic intubation, supraglottic masses, so on and so forth. But oftentimes these are the more challenging cases that I encounter, more so from the standpoint that these patients are frequently misdiagnosed, mistreated, and anesthesiologists on a regular basis find themselves getting into issues with this type of airway pathology. So the title of my talk is Time for Paul's Approach to Airway Management in the Setting of Laryngotracheal Stenosis. For the sake of this discussion, I do not have any financial interests to disclose. And we're going to touch on briefly first definitions of laryngotracheal stenosis, focusing specifically on posterior glottic stenosis and subglottic stenosis. I'll discuss some of the pertinent anatomy. Again, I don't want to insult anyone's intelligence, but just to refresh on some of these topics I think will be helpful. And this kind of goes hand in hand with the classification, so the different classifications for posterior glottic stenosis and subglottic stenosis. It will identify, more importantly, some of the predictors of laryngotracheal stenosis, how it's surgically managed, and then, of course, an approach to successful airway management. So again, why should we care about this? Why am I standing here in beautiful Palm Springs talking about laryngotracheal stenosis? And again, it comes down to people mess this up all the time. It's frequently missed. Providers get themselves into a cannot oxygenate, cannot intubate situation. Frequently I'm asked to review these cases as well as part of being a part of the Society of Head and Neck Anesthesia. So I figured we start with a case report that kind of hits close to home. I actually took care of this patient several years ago. For some odd reason, it's stuck in my head since that time about how we could have better managed this patient, how the outside institution could have better been educated on how to manage this type of airway pathology. So it's a 43-year-old male involved in an MVC. More specifically, and this is a frequent occurrence in the state of Michigan, motorcycle versus deer. Prior to this, no significant past medical history, but the patient sustained multiple injuries, including injuries to his cervical spine, thoracic spine, and multiple rib fractures. He underwent urgent emergent T4 laminectomy and T2 through 7 infusion. During his hospitalization, he was not extubated following the procedure, remained intubated, went to the ICU, and then was subsequently trached approximately 10 days later. They felt that he was stable enough to go to SNF, so he was discharged to a skilled nursing facility. Approximately 1 month later, returned from presented to an outside hospital, admitted in acute hypoxic respiratory failure. They presumed the etiology was aspiration or aspiration pneumonia. They obtained a multitude of radiologic testing, including a CT neck, which showed a small but growing tracheoesophageal fistula. And during that hospitalization, his trach was decannulated. He was treated. And they felt, again, that he was stable for discharge to a rehabilitation facility. Now, 4.5 months later, again, presents to an outside hospital, acute hypoxic respiratory failure with significant decline. They felt in the emergency room at that point in time that he required intubation and prompt transfer to the ICU at that institution. Importantly to note that his stoma was well healed at that point in time. They induced and they attempted to intubate, multiple attempts at intubation, and they just felt that they could not advance the tube and there was a possible stricture. They were successful to some degree of advancing a tube into the what was presumed to be the trachea, but every time they intubated with I believe it was a 5.0 MLT, there was worsening hypoxia. So you can kind of tell where this is going. The patient was placed on high-flow nasal oxygen, was transferred actually to our institution, where he was admitted directly to the ICU and promptly brought down to the operating room. We called a critical airway at that point in time, which brings all the resources together, including anesthesia, ENT, the ACS team, so acute care surgery, as well as the appropriate nursing. They performed a bedside or an awake bronchoscopy once we had them into in the operating room, and as they advanced their scope, posterior oropharynx looked fine, vocal cords looked fine. They got below the vocal cords and they saw this. Pretty substantial subglottic stenosis, probably along the lines of 50 to 70%. Which, as you can imagine, is a little bit challenging to advance, even a 5.0, and can cause some significant trauma. Now, they weren't able to advance their standard bronch beyond that stenosis. We removed the scope. ENT advanced a pediatric slim scope beyond the stenosis, and to no surprise, this is what they found. And folks, this is not the carina. This is a pretty significant gap. And that tracheoesophageal fistula had grown quite significantly. A CT was later obtained, and you can kind of appreciate this a little bit better, but there's this stenosis, which again, probably around 50 to 70%, and then the dividing tissue between the trachea and the esophagus is pretty deteriorated. And really, it wouldn't have been much of an issue if it was just a tracheoesophageal fistula. But the real issue that we ran into was this stenosis, because a tracheoesophageal fistula can be surgically managed, stented, so on and so forth. But the fact that they were at the outside hospital advancing an endotracheal tube, desaturation every single time, it was just going directly into the esophagus, and the stenosis was the barrier or guiding marker. And I'll come back to how we actually managed this patient in a little bit. Just as a spoiler alert, it was a safe outcome, I should say. But some patients are not as lucky, and as if you plug into PubMed right now and Google subglottic stenosis failed intubation, there's going to be a laundry list of cases that pop up. And that's kind of why I bring attention to this, because it could happen to any of us, and there's warning signs that exist in patients' history, and we'll kind of go through that a little bit. But for example, this was a case published in a Korean Journal of Anesthesiology, and it was a 69-year-old patient presenting for an elective procedure, a total knee arthroplasty, had some history of dyspnea on exertion. I, for some odd reason, chose to do it under general anesthesia. I don't know the specifics regarding that, but it was a failed intubation nonetheless and required emergency airway management. Similarly, unexpected difficult tracheal intubation secondary to subglottic stenosis. This was a case of a 26-year-old female presenting for hysteroscopy, uterine biopsy, and had, again, some vague history of dyspnea on exertion, which is not common in a 26-year-old female, and it didn't raise any red flags, I presume. Unfortunately for this patient, she ended up with an emergency front and neck airway. Along the same lines, and you kind of get the theme here, a young 36-year-old female presenting for elective sinus surgery. Again, emergency trach for failed intubation. And then lastly, another example This was a 65-year-old male. And this patient, there should have been a lot of red flags that came up: prior trach, prior radiation to the larynx, prior resection of cancer in the posterior hypopharynx. So there's a lot of red flags that should have popped up. But nonetheless, they struggled to secure an airway in this patient. So you can kind of get the sense that this could happen to anyone. And I just want to, again, I don't want to insult anyone's intelligence. I just want to bring attention to this. And maybe in the back of your mind, even if a few of you take something away, it'll stick in the back of your mind that, hey, if something doesn't feel right, it's probably not right. So again, we're talking about laryngotracheal stenosis. I'm going to speak specifically regarding posterior glottic stenosis and subglottic stenosis. Tracheal stenosis, the management can be somewhat similar to subglottic stenosis. However, it gets into, particularly the distal obstructions, it gets into the thoracic realm of things, which is a completely different talk. But just briefly, as an introduction and definitions for laryngotracheal stenosis, it seems pretty obvious, but it's a narrowing of various subsets of the upper airway, including glottis, supraglottis, subglottis, and trachea due to pathologic scar formation with severe and potentially fatal respiratory compromise. And it actually follows a normal wound healing process. This isn't anything completely unusual, at least with regards to the iatrogenic causes. So there's some degree of insult to the tissue, inflammation. You have your macrophages come in, eventual fibroblasts, deposition of granulous tissue, and then eventual scar formation. So it's nothing, extreme, but sometimes this process becomes dysregulated to some degree. Now, speaking with regard specifically to posterior glottic stenosis, this involves the posterior 1/3 of the vocal cords, okay? Posterior commissure, and more importantly, and probably more critical, is when it involves the cricoid-arytenoid joints. Typical causes for this or prolonged or traumatic intubation, as you can imagine. And I put a subset of past medical history and genetics because that has a strong influence on how well we heal. For example, if a patient's poorly controlled diabetic, they may not heal as well or as normal, as we would presume normal, as a normal healthy patient. Prior surgery, of course, to the vocal cords, for example, removal of a vocal cord polyp. Autoimmune diseases, interestingly, plays a pretty significant role in this, such as lupus, sarcoidosis, amyloidosis, so on and so forth, all play a role or could potentially play a role in the incidence of posterior glottic stenosis. Inhalation injury, as you can imagine, could play a role in this, and external trauma. And you can kind of see in this picture, maybe it might not be as obvious, but if it's starting to show what they call banding. If you see banding in any of the reports, you should be somewhat concerned. And these predictors are well studied. This was actually an article forwarded to me from one of my ENT colleagues. It was published in the Annals of Otolaryngology, Rhinology, and Laryngology. And it looked at the incidence of posterior glottic stenosis across multiple institutions and tried to identify predictors that they could convey to their individual institutions so we could better prevent these things from happening. And they had data for 28 patients, or they identified 28 patients that met their inclusion criteria, 112 controls. And the predictors that they found after their multivariate analysis was intubation greater than 11 days, which seems pretty obvious. Diabetes, of course, it comes back to the potential wound healing issues. Ischemia, and they referred to ischemia kind of vaguely, and it was referred in the discussion of the article about more so ischemic conditions, so hypotension while in the ICU, significant cuff pressures, larger endotracheal tubes, so on and so forth. And that kind of goes hand in hand with the endotracheal tube size, 8 or greater in males for some specific reason. And whenever we go to the ICU for airways, it always makes me cringe when particularly when we go to the respiratory ICU and the intensivist is asking for an 8.5 or a 9.0 tube. I'm like, come on, you're driving me nuts here, because this is a recipe for disaster. And then for these types of patients, they identify with these risk factors. Patients with posterior glottic stenosis benefited actually from early trach. Now this slide's a little busy. I don't want anyone to get too bogged down in this. Type 1, I just want, for the sake of discussion, I just want everyone to be able to at least identify the more concerning types, and if they ever see it in a patient that's coming either to the operating room, emergently, elective, they can at least know which ones they should be more concerned about. So type 1, it's the typical banding, so intraretinoid scar. You can see it quite obviously if you ever do like an MPL on a patient in the preoperative area. Type 2 would be involvement with the intraretinoid joints, but sparing the cricoid joints. Type 3 would be the involvement of one of the cricoid joints, posterior commissure, and then type 4 is pretty severe. So it involves posterior commissure in both cricoid joints. Remember, normal mobility of the larynx will no longer exist in those specific cases. Now, it typically presents weeks to months. Initially goes unnoticed. Some patients say, hey, my voice seems a little raspy, or someone's family member says, hey, his voice doesn't, he or she's voice doesn't seem quite right. And then it can progress rapidly. So mild dyspnea to stridor to acute respiratory distress. And believe it or not, this progression that we're seeing here in these pictures is actually the same patient. And you can kind of see there's some degree of inflammation, insult in item A, and it gradually progresses down to complete distortion of the glottis. So I posed a little trivia question. Why is posterior glottic stenosis more susceptible, or the posterior glottis more susceptible to injury? Does anyone have any guesses? Give it to me. Jefferson table? No? No, I'm kidding. And it actually stems back to embryology. So posterior glottis is derived from the 6th pharyngeal arch. The glottis in general is made up between a combination of 4th and 6th. The posterior is composed of respiratory epithelium, which is very delicate. Anterior is actually composed of squamous cell, which is more protective, resilient to some degree. Now, surgical management for these cases typically involves early surgical intervention. Mature scar can be quite challenging to manage. Patients often require a trach, maybe more so with the type 3 and 4s, 2 potentially. Type 1 can typically be managed with an endotracheal tube, jet ventilation, or dilation up front. And I feel like, particularly for the type 1s, start with conservative endoscopic procedures. As I mentioned, CO2 laser, balloon dilation up front, or Jackson dilator, and then the steroid and mitomycin C injection. And does anyone recall what the mitomycin C actually does? Anyone? Some people forget it. It just prevents the deposition or inhibits the increased collagen deposition. And then endoscopic glottic reduction surgeries are rather invasive, but they are more definitive types of procedures. So the risk of recurrence goes down relatively significantly with these types of treatments. And then, of course, the open posterior cricoid expansion, which it is an aggressive procedure, and there's varying outcomes with that as well. And this is just an example of the transverse chordotomy and anterior medial arytenoidectomy. It's not pretty to look at, but again, it is more of a definitive type of procedure. And now switching gears a little bit to subglottic stenosis. Again, it involves mostly the cricoid cartilage and upper tracheal rings and just below the vocal cords. Similar causes for the iatrogenic causes, so traumatic or prolonged intubation, prior trach, of course, external trauma, inhalation, injury, and then genetics, again, with the wound healing, certainly does play a part, and that's a bit of the unknown that we have with this type of condition. And I put a star next to the idiopathic, because these are the ones that often go untreated or misdiagnosed for an extended period of time, and it's not an issue until it is a real issue. And it's typically the result of dysregulated wound healing. Now, I wanted to speak specifically on the idiopathic subglottic stenosis because some of those cases that I had mentioned were likely related to this. It actually involves worldwide 6 to 8%. It's rare, but it happens. And the proposed mechanisms behind this have something to do with the fibroblast and fibroinflammatory marker profile. There's been discussion, and again, this is very tedious, very specific, but interleukin pathways, specifically 23 and 17A for any of the scientists out there. And then, of course, estrogen. So we see this in middle-aged females. Why? Clearly, someone thought about it, and there's still further investigation that needs to be completed. But estrogen certainly does play a role, not just in wound healing, but in this disease process. Now, there's also been certain risk factors for developing subglottic stenosis and tracheal stenosis that have been studied. This was a very large study that they identified over 6,000 patients with intubations over a 6-year period in the medical ICU. 136 of them developed subglottic stenosis or tracheal stenosis, and of course these patients were matched to controls with similar comorbidity scores, and these are the risk factors that they identified. So prior trach, I buy that. Current smoker, so smoker obviously coming before they came into the hospital, COPD, bronchoscopy while in the hospital. And I would imagine that has something to do with positioning with the endotracheal tube and manipulation, causing increased stress force on the tracheal tissue. Reflux, again, that seems to be a common theme. Again, the autoimmune diseases, so lupus certainly plays a role, and then treatment of pneumonia or bronchitis while in the hospital. Now, presentation, it's variable. Some weeks to months, some, as I had mentioned, particularly in the idiopathic, it's all over the place. But typically presents with dyspnea on exertion, stridor, inspiratory stridor, right? Not expiratory, inspiratory stridor, versus idiopathic, which again is frequently misdiagnosed. Again, I want to talk on the different grading scale, just so if you ever see it in a like ENT note or an ER note, just so you can have what the warning signs might actually be. You should be concerned about grade 2 and worse. So grade 2 starts at your 51 to 70%, which is probably closer to what we saw with that patient there. Grade 3, 71 to 99%, and grade 4, well, no detectable lumen. Most likely he or she is a candidate for a tracheostomy. Now, conservative endoscopic procedures, it follows a similar pathway of the posterior glottic stenosis, so CO2 laser, balloon dilation, Jackson dilator, steroid injection actually inhibits the wound healing or progression of the disease in all phases, and then the mitomycin C inhibits collagen deposition. And then more definitive treatment, again, is the cricotracheal resection, which has a lower risk and has been studied quite well, lowering the risk of recurrence, but there's still variability of results with regards to complications and things of that nature. So if you have a patient, hopefully not emergently, but if you have a patient come to your OR that you suspect one of these conditions, how should you proceed? And my first recommendation is time out. Get the group together. If you're in an academic institution, there should be an anesthesiologist on call. There might be somebody that has some expertise in difficult airways or difficult airway management. Have ENT present. Patients should not be induced with anesthesia without an ENT evaluation, particularly in some of these more severe cases, and have the appropriate equipment in the room. So there needs to be a discussion with the ENT. Was there an MPL completed? Was there specific imaging? I like a CT neck to at least appreciate that cross-sectional area of how significant the stenosis is. Also location. If you take note of that in the initial case report that I presented, that was right around the manubrium, which can be a little bit more challenging to complete a trach. And I remember in the initial discussion regarding this patient, there was doubts whether or not we would safely be able to perform a trach up front, which is why we went down a certain road. Is there any confounding factors that may inhibit a certain type of treatment from being successful, such as jet ventilation? If the patient's significantly obese, they might not tolerate jet ventilation. They may last 30 seconds or not very long at all. Is there significant physiologic factors at play, such as RV dysfunction, pulmonary hypertension, COPD, emphysema, so on and so forth? And then, of course, patient goals of care. We're osteopaths. We're trained to take that into consideration. It's not to say that MDs aren't, married to one. But just keeping that in mind, that some patients, they don't want a trach. And they're perfectly fine just living the rest of their lives, even if it's a couple days without a trach, because it's consistent with their goals of care. So we always have to keep that in the back of our minds as well. And then there's two different routes you can go with the treatment of these cases. So is there going to be an awake trach? Particularly in those severe cases of posterior glottic stenosis, it likely is, versus induction of anesthesia. And again, this is a combined decision with your surgical colleagues. Certain equipment you need to have available. If you ever go into one of my ORs, I feel like I've exhausted all of the resources from time to time. Having a variety of video laryngoscopy, direct laryngoscopy. I typically will not bring a patient to the operating room with these types of conditions without at least having a jet ventilation system nearby, preferably the Monsoon, which is listed here, which is kind of the standard of care nowadays. And then, of course, making sure that the nursing staff has the appropriate equipment ready to go for the surgeons. And, dilators, a variety of them, some with the balloon dilators, some may not be amenable to balloon dilation up front. And then, of course, a trach tray as your emergency backup. Having the appropriate personnel in the room, having more experienced. I know a lot of our airway algorithms included in the ASA guidelines nowadays include having experienced personnel in the room, and that includes the surgical attending. You do not want to induce anesthesia if it's the ENT and resident who's a PGY2 sitting there and is supposed to manage this patient. Pre-incision and induction timeout. I do this quite frequently. I actually insist on it, and it's kind of included in my standard of practice, particularly in head and neck cases. But I feel like including this, laying out what the plan is, what the backup plan is, what the backup to the backup plan is very important. And then, of course, emphasize closed-loop communication. If you're going to initiate jet ventilation up front, both you and the surgeon are going to be looking if it's effective. Shortly thereafter, if something changes, it's a dynamic situation. You need to be on your toes and if jet ventilation fails, hey, get the endotracheal tube up, mass ventilation, so on and so forth. Now for induction of anesthesia, of course we all pre-oxygenate. In the physiologic difficult airway guidelines that we have today, I've spoken on it before in Thrive Talk last year, but there's this discussion around tubeless anesthesia. I've actually given a grand rounds on this. I'm a huge advocate for Thrive, which is really just the use of high flow in the operating room, and it's truly very effective in the management of patients with this type of airway pathology, if anything, as a pre-oxygenation modality, because you can maintain high flows without any respiration and still provide effective oxygenation for minutes, half hour, 45 minutes, depending on how significant the stenosis is, and it still is effective in CO2 clearance. And then again, coming back to that differentiating that crossroads, whether or not you're going to pursue an awake trach or an awake intubation or an asleep. If you're going to pursue an asleep, RSI is typically the standard. Promptly providing mass ventilation after the RSI drugs are in place. Establishing mass ventilation is key because that's kind of our safety net, right? And then assuming that you can mask ventilate the patient, or even if you can't, transitioning the airway off to the ENT who may pursue dilation up front intubation, initiation of jet ventilation, all of which has to be laid out ahead of time what those steps would actually be. And then maintenance of anesthesia for this type of a procedure is typically done under TIVA just because there's a lot of changes. You can obviously maintain anesthesia with inhaled anesthetics. In a jet ventilation case, it seems very obvious. Emergence. Equally as important as intubation and induction of anesthesia is emergence. And having a discussion during that timeout, what the plan is going to be for emergence is really, really important. Again, having the appropriate personnel in the room. You do not want the surgeon running off dictating and not being present in the room, just in the event that there's an emergency that takes place. Having your emergency airway equipment, I like to keep the glide scope and fiber optic scope in the room until the case is completely finished and the patient's on their way to the PACU. Effective reversal of neuromuscular blocking agents. Nowadays we have Twitch View, we have train of 4 monitors that are quite effective and sensitive to the measurement of effective neuromuscular blockade reversal. And then also making sure that the patient's spontaneously ventilating. If you're going to emerge from anesthesia after dilation and you have an LMA or an endotracheal tube in place, promptly getting the patient back spontaneously ventilating is going to set yourself up for success. Having some degree of pharmacologic adjuncts for anxiolytic and analgesia. I like the Remy wake up. It's just it's what I've been trained to do. Some people like Precedex. Either way, you can get a patient at certain levels spontaneously breathing and make sure that they're still comfortable. And then extubate. What your plan is going to be for extubation? Is it going to be to a mask? Is it going to be again to Thrive? And again, patients tolerate Thrive quite well, so that's usually my default and what I'm comfortable with. Now, coming back to that case report, just for completeness sake, I figured we'd see how it ended here. So when the patient actually came for their definitive procedure, we had tried awake fiber optic intubation. The initial thought was using a 6.0 NIM tube. The reason being is because they were concerned whether or not they were ever going to preserve the recurrent laryngeal. So it's a little atypical, but we gave it a shot. So we actually let the resident at the time attempt, and it was unsuccessful. He could get to the stenosis, but could not advance beyond. He couldn't advance the scope beyond. I attempted with a 5.0 MLT. I could advance the scope beyond the stenosis and get into the trachea, but when we went to advance the tube, it was getting held up on that large gap where the tracheoesophageal fistula actually was. So we put our heads together, and eventually we were successful to some degree, with a 6.0 Parker Flex, which has that little nub on the end. So it was able to glide past the tracheoesophageal fistula once we were able to get the scope into the airway. I think it's important to note that this was a very slow process. I've never been involved in an airway that took this long. It took a little bit over an hour to actually get an endotracheal tube secured in this patient. But I think some of this is a testament to the patient. It was very compliant, and we were able to get him comfortable enough that he would still be able to follow commands, spontaneously breathe, but play along with us to some degree. There was a decision after we had that endotracheal tube we presumed as close enough as we possibly could to in place. We confirmed end-tidal CO2, and we were getting appropriate volumes, but there was concern that this, and you can see it on the scope, I wish I had a picture of it, but it was kinked. And there was, again, coming back to that concern whether or not we would be able to trach the patient. It was a little hairy there for a moment, but the surgeon I trust, and I feel that if he says he can trach the patient, he could trach the patient. Of course, we had an ECMO team and a cardiac anesthesiologist on backup as well. So we proceeded with induction, and they trached actually up front there. Now, with regards to the surgical resection, they performed a neck dissection. They removed a huge section of non-viable trachea, approximately 6 centimeters. And this was an ongoing discussion throughout the procedure, but they were unable to attain primary tension-free anastomosis. So they repaired the tracheoesophageal fistula, and they felt that it was a good closure, but ultimately the patient returned to the OR the next day for a total laryngectomy. And this was after an 18-hour plus procedure. So again, I think it was probably the best outcome given the situation, but you know, it's still in the back of my head whether or not we could have done something better, or if we could have better educated some of the people at the outside institution. Nonetheless, that's all I have for you guys. And I'm happy to answer any specific questions, or we have time at the end to answer. Okay, all right, fair enough. Thank you, everyone.
Thank you so much, Dr. Grenda. Just an example of how exciting the OR can always get. As a pediatric anesthesiologist, I get excited about a tracheoesophageal fistula in a neonate, not necessarily the adult. So thank you for sharing that case report. Keeps us all on our toes. So thank you so much. Next, we will be joined by Dr. Shelley Iverson. Dr. Shelley Iverson completed her internal medicine residency and subsequently completed fellowships in both pulmonology and critical care. She was working as a pulmonologist and intensivist before returning to training to complete an anesthesiology residency. She is currently working in an academic center doing both general OR cases and ICU medicine, and is actively engaged in medical student and resident fellow training. Today, she will be speaking about perioperative care of the ICU patients, tips for generalists. So please join me in welcoming Dr. Iverson.
So as you heard, I've had a little bit of a wayward path along my training, but ultimately I'm happy in both the OR and the ICU realms. My only real disclaimers is one, I do adult medicine, neonates and TE fistulas just give me anxiety. And this talk is really geared toward those people that are not at academic centers or who may not have resources 24/7 that you can bounce ideas off of. And these are just generalized tips that may make your life easier if you have to take care of people that are ICU patients or just sick in general. I have no financial disclosures. Objectives, we're going to briefly talk about some ICU statistics, and then in a systems-based format, sort of top to bottom, talk about different pathologies that some of the ICU patients may have that you'll see, and then we'll just end with a couple take-home messages. There are millions of ICU patients admitted annually, and obviously with COVID, these statistics are even much larger. There's a little more than 55,000 ICU beds just in community hospitals nationwide. And for all surgical patients, the mortality is about 1% at 30 days. And as you can imagine, for our patients that are already in the units, those mortalities are higher. So starting neurologically, there are millions of TBIs annually, and about 10% of those actually are going to get admitted. And while some of them are going to die on scene or in your ER of a primary injury, it's really the secondary injuries that people die of while they're admitted that we have direct impact on. The severity of TBIs is going to be based upon the GCS, but for us, for all intents and purposes, if they're intubated because of a head trauma, just consider them severe. The secondary injuries, the things that we can directly impact, are things like hypo and hyperglycemia, their temperature, whether or not they get hyperthermic, and then sodium abnormalities in particularly if they end up hyponatremic. While the goals of our management is to lessen or to reduce the chances of secondary injury, this is largely accomplished through maintaining the cerebral perfusion pressure. And so often simultaneously we're increasing the MAP or decreasing the ICP. And this is where your choices of what we're going to normally do during our cases really becomes paramount. And so for the TBI patients, this is the one time that saline is probably your preferred crystalloid. You really want to avoid things that are hypotonic, remembering that LR itself is hypotonic. No dextrose fluids unless your patient is hypoglycemic and you need to treat that. And there's actually a higher mortality associated with colloids and specifically albumin. Most of my partners, I say that because I don't know anything about you, but most of my partners are not comfortable with maintaining blood pressures really outside of phenylephrine. When we start talking about epis and norepis, people start getting a little twitchy. And so often we use vasoactive drugs, but there is more and more data coming out that phenylephrine may not be as benign as we think it is. And now there's reason to think that it may be associated with some cerebral constriction. And we do know that it's associated with postoperative delirium, which actually carries its own mortality. Conversely, norepinephrine has never been associated with harm and is probably what we should be reaching for if you needed it. Things that we can do to decrease the ICP, so just elevating the head of the bed. And if your C sign is not yet cleared and they're on a backboard, just reverse Trendelenburg so their head is up. Hyperventilating, remember that your goal is a PaCO2 in the high 20s or about 30, and that's not always synonymous with what your end-tidal CO2 is. The PaCO2s less than 25 are actually associated with worse outcomes. And hypertonic comes in different concentrations, but this is the one time where you actually do need central access if you're giving a hypertonic solution. Mannitol, you can dose 0.5 up to a gram per kilo, and then ultimately surgical interventions are the definitive treatments. Moving on to delirium. Delirium, we all know, is a reversible encephalopathy. Postoperatively, it can actually occur up to about a week after surgery, and so often people think it's just the first day or two, but it can actually appear on day 4, 5, and 6. There's clinical presentations. Most of us, when we think about delirious patients, we're thinking about the patient that's pulling at lines and tubes and wire, but they can be actually inattentive and very unengaged and just sort of slow to respond. And patients can actually wax and wane and alternate or fluctuate between any of these presentations. Most of the risk factors, unfortunately, are non-modifiable. If your patient already has underlying cognitive dysfunction, baseline, or substance abuse, so they're just kind of old and sick, they're just more likely to have it. But things that we can directly impact include things like polypharmacy, and then their sensory impairments. You know, we take their hearing aids and their glasses in pre-op and that sort of thing. Surgical risk factors, as you would imagine, the bigger the case, the more likely they are to need ICU afterwards, the more likely they are to be delirious. And then again, the mortality is not small. So polypharmacy, anything that we can do to lessen mood-altering agents, ideally we should do. It doesn't mean that we don't treat the patient. It doesn't mean they don't get opiates if they need it. But maybe the 85-year-old patient who has dementia doesn't need the 2 of midazolam to roll back to the OR. Ketamine and gabapentin as well. And again, we talked briefly about phenylephrine. You know, I'm equally guilty of taking glasses and hearing aids, largely because I don't want to have to replace them. But making sure that those are in place when your patient wakes up. So this way, as they're coming out of their anesthetics, they're able to see and hear. Using more of a multimodal pain control doesn't mean they don't get opiates, but just perhaps less reliant on them. And avoiding prolonged fluid fasting. Fluids in particular are associated with increased delirium. And then lastly, the use of dexmedetomidine, if your patient can tolerate it, if it's appropriate, is actually associated with less delirium. Moving on to cardiovascular, there's a couple things here we're going to touch on. Hypotension in general is associated with increased morbidity and mortality, and we know that, and we'll talk about that in the renal considerations as well. The only real modifiable risk factor that's associated with intraoperative hypotension is the use of propionfent with induction. Doesn't mean it's a bad combination. I do it all the time. But what it means is if I know I have somebody who's going to be hypotensive and I'm thinking, I'm just going to have to get them out, going to be pushing X and Y and Z, I just don't use that combination. Intraoperative hypotension is defined as a MAP less than 60 for more than 20 minutes, less than 55 for more than 10, or a systolic less than 90 at any time. So inotropes and vasopressors, often people will think that they're synonymous, and while both of them are going to increase the blood pressures, the mechanisms actually differ. Inotropes will do it through increased contractility, and ultimately the cardiac output increases, and that's just through their beta receptors. Vasopressors, which is essentially just phenylephrine, only works through the alpha receptors, and often we all know we get this reflex bradycardia. That's actually associated with a decrease in cardiac output. Again, often not tolerated by some of the patients that we're going to talk about. I really like this graph. It's actually from an anesthesia article back in 2017 looking at the safety of norepinephrine for C-sections and spinals. I'll just draw your attention to the bottom where it talks about the relative potency. So 100 mics of phenylephrine is about the equivalent of 8 mics of norepinephrine. And if your pharmacy uses standard concentrations, comes in a gold bag, that concentration is 16 mics per ml. So you can dilute it down and make an 8 mic stick. And that's usually what I do. Couple patient populations I do want to touch on just because you all may not see these as often, or when they do, everybody gets a little anxiety. So LVADs, this is more my realm. I work in a cardiovascular ICU, and so I see these quite a bit. They've been around for decades, been FDA approved initially since the 90s, and they're now destination therapy for more than 18,000 people. So you will see these. While the older versions attempted to really mimic the normal cardiac function where you felt a pulse, the newer LVADs and those that are in your communities are what we call continuous flow. Unfortunately for you, that means that your pulse oxes are not going to read. And it also means that if you are concerned about some sort of a hypoperfusing ACLS rhythm abnormality, when you go to do your pulse checks, they will not have a pulse. Okay, so we'll talk about that as well. Current indications are bridge to transplant, bridge to decision, and ultimately destination therapy. The mechanism is both volume and pressure unloading and LV decompression. And in a small subset of patients, actually, they can have enough native cardiac function that returns that we actually will explant LVADs. So not all people need them lifelong. Sometimes it's a viral myocarditis, for example, and it's just going to take that patient several months to get back on their feet. They don't need a heart transplant, but they also don't need to be in the hospital all the time. And again, the majority of LVADs are now at home or in your communities. These newer continuous flow LVADs are actually associated with less strokes and increased survival. And there are different brands, but HeartMate-III is the one that you're going to see. It's most common in the United States, so that's just what we're going to talk about. The little schematic on the bottom right that shows the internal picture, I just want to kind of show you what we're talking about for terminology. There is actually a cannula that is in the LV apex, and it sucks blood into a pump or into a motor, and that's called the inflow cannula because it's sucking blood in to the motor. Whereas there's a connection that goes from the motor bypassing and go directly to the ascending aorta or the outflow, and that is the outflow graft. There is also a little line, a little drive line that actually connects to the motor itself, and that's actually on this next patient or on this external view. That's actually going to be the connection that the patients will have that connects to a control panel. So there's internal components and external components. Ultimately, a control panel hooks to 2 batteries, and the patient wears these 24/7. This control panel, though it looks intimidating, has a bunch of buttons, and if these people come to you, whether it's an elective case like an endoscopy or an emergent case, urgent case, you should be looking at their settings. There's no setting, no button that you're going to push that's going to hurt this patient. You're not going to reprogram anything, nothing to be intimidated about. But there's different settings and parameters that you need to know about because intraoperatively it's going to matter what your treatments are. Really what you're caring about are what the speed, the flow, the power, and the pulsatility index is. Speed is the only one of these that is adjustable or is set, and that is usually done by the cardiologist. That's not anything that we're going to adjust. The flow and the power are exactly what you would imagine them to be, and they will adjust automatically to try to achieve the setting for that speed. The pulsatility index is a little harder to conceptually grasp, and it's just a magnitude of what the associated or the estimated flow is through the LVAD, and it's a marker for what the native cardiac function is. Sorry, I thought it went the other way. The PI, or the pulsatility index, is on a 1 to 10 scale, where the lower the number, the more reliant the patient is on that LVAD. So as the LVAD itself contracts and blood is forced through the LVAD by the heart's contraction, more blood goes through and there's less reliance on that LVAD. Clinically, you care about this because if the PI starts alarming, if your pulsatility index starts alarming in the OR, Clinically, it means that you have a decrease in preload or volume. And what this means is your patient doesn't need the phenylephrine or the norepinephrine that you may be using to maintain these MAPs. It doesn't mean that they need the bolus of LR, whatever your fluid is. It means that they need blood. Even when your surgeons, I don't know if your surgeons underestimate like mine do, but even when your surgeon says, oh, we're not bleeding, if your PI is alarming, they need volume. And so again, clinically correlate, but more than likely in the OR, it's gonna be blood. This was actually a screenshot that I took from one of my fresh VAD patients. And I just want to point out what a normal arterial line tracing looks like in someone who's really non-pulsatile. So you can see that a lot of the red squiggly lines are just small squiggles, right? They're not really pulsatile. But it may be a little difficult to appreciate, but on the far left of the screen, you can see half of a complex. There's a couple complexes that are sort of different morphology in the middle, and then there's one that's gonna be at the very end. And this is just what it looks like when the pulse is generated by the LVAD itself. The speed will ramp up and will ramp down about every 2 seconds. It's pre-programmed in an attempt to lessen stasis and ultimately lessen strokes. So you will have these morphological looking complexes that may not change or correlate to any heart rate changes that you see, but it is a change in pulsatility, and it is by design to lessen the chances of strokes. Again, because they're non-pulsatile, often cerebral oximetry is what you're gonna need because ears, noses, and fingers often don't read normal pulse oxes. These patients are usually fully anticoagulated with Coumadin, and their goal INR is 2 to 3. In the event that you think your patient has a symptomatic rhythm where they are non-perfusing, where you would normally do your standard pulse checks, often these patients are not going to have these pulses that you're going to be able to palpate. And so if you have somebody who you feel like is symptomatic, you know, cool, clammy, diaphoretic, all the things that we know to be, if their MAP is less than 50 and their end-tidal is less than 20, then that is the equivalent of death in an LVAD patient, and CPR with compressions and ACLS drugs should be started, okay? So this is an ACLS algorithm that is specific for LVAD patients. It is part of the ACLS algorithm, but it is a different appendix, so it may not be what you're normally used to seeing. Complications of LVADs can be specific or LVAD related. I just want to point out the LVAD related because these patients will bleed and they will be in your endoscopy suites. By the nature of this pump, they end up with an acquired von Willebrand deficiency, they end up with AVMs, and then they're fully anticoagulated on Coumadin, so you will see these people, they do bleed. If you need to troubleshoot an alarming or a problem with an LVAD patient, there's sort of an ABC mnemonic, A being alarms, and actually auscultating. You will hear an LVAD hum. It is not subtle, you will actually hear it. Batteries, you want to physically look and see, are there batteries that have power? Looking at the settings on the controller and reviewing alarms, and then inspecting the driveline itself. Sometimes the drivelines can get cracked or they can actually get disconnected. E being echoes if you have the ability for a peri-op TTE or TEE. And then just because they're not transplant candidates doesn't mean they're not ECMO candidates. And so if you have somebody who's really struggling and you have the option for doing ECMO, it's worth a call to talk to your CT surgeon about, and then potentially transferring if you're not at a center that deals with these. Anytime you're concerned about this, or anytime you have a patient who's going to be under anesthesia for a while, unless you want to be doing Dopplers every couple of minutes to check blood pressures, you really want to get an arterial line so you can actually get maps that are accurate. And then every VAD patient, even if he or she is not a candidate for transplant, they belong to a transplant center, and there's a cardiologist on call 24/7 to deal with calls. So at 3 in the morning on Christmas Eve or New Year's Eve, if you have a VAD patient and you're like, I don't know what to do with these, call their center. They will walk through pushing the buttons. What does it display? What does it look like? What does it mean? If that's not an option for you, or for whatever reason you don't want to do that, there's many different algorithms that you can look at. I like this one because it specifically shows if your power fluctuates up or down, if your PI is going up or down, or if your speeds are changing, what potential etiologies could be. Moving on to pulmonary hypertension, there's now a new definition for PH. It's a mean PAP greater than 20. Okay, so we lowered the criteria on purpose to try to identify these patients so they are treated earlier, because the 5-year survival rate is just abysmal. There are 5 groups of pulmonary hypertension. Most of us think of group 1 or PAH as what we think of as our prototype for pulmonary hypertension. And these are usually the hereditary or the autoimmune diseases, the younger patients that we often see, connective tissue diseases. I do want to point out infections like hepatitis C and HIV are associated with PAH. And this is separate from the control of the disease. So you can have an HIV patient with a viral load that's undetectable, a CD4 count that is normal, and he or she is compliant with meds and they have no symptoms or no issues from their HIV, they can still develop PAH. Same with hepatitis C. Group 2 is due to any kind of heart disease. Group 3 are your chronic hypoxemics, including your OSA and OHS, especially those that are non-compliant. Group 4 is your chronic thromboembolic pulmonary hypertensives. And then group 5 is just multifactorial, your grab bag. And this is where a lot of your hematologic, like your sickle cell anemias, come into play, and your dialysis patients. The general outpatient management is really just aimed at optimizing whatever the etiology is for that patient. Specifically, group 1 and group 4 patients need to be anticoagulated with Coumadin. Though some people use off-label NOACs and DOACs, they are not yet FDA approved, and really group 4 in particular will still clot through your Eliquis or your Xareltos. And so right now, still Coumadin is what is preferred for these patients. What that means clinically is often we can't just hold Coumadin for 5 days and let them wash out, okay? And so either the patient gets started on treatment dose Lovenox and it just gets held prior to the procedure, or if they've got renal disease or for whatever reason can't do it, then the surgeon needs to bring them in and start an IV heparin drip because they need to be anticoagulated. Anesthetic-wise, when we just talk about routine bread and butter cases, so not cardiac surgery, not your ruptured AAA, just your routine bread and butter, appies, hernias, et cetera, the mortality and morbidity is really high. You can imagine the more sick your patient, the bigger the procedure, the worse they're going to do. Specifically, there are patient factors, and if your patient's etiology is chronic thromboembolic or group 4 PAH, they tend to do really poorly with surgery. They don't tolerate it really well. And so you want to really step up your game if the etiology is group 4. If their 6-minute walk distance is less than 300 meters, they're going to struggle with you. And then if their NYHA grade is more than 2, they're likely to have problems. Again, just a table showing that the routine cases like hernia repairs, cholecystectomy, sort of our bread and butter things, actually carry intermediate risks of perioperative mortality and morbidity. So anesthetic-wise, you want to review the workups and really, if you can, talk to the person who's managing them. You need to know what to do with regards to their medications and then bridging for them. Intraoperatively, you're probably going to want an arterial line. I usually will do mine pre-induction, so patients are wide awake in pre-op. You want to do everything you can to maintain sinus rhythm. So if your patient is predisposed to something like paroxysmal AFib, I have defib pads on before I go to sleep. And I do cardiovert in the OR while they're asleep. My surgeons just step back. It's okay. You want a hemodynamically stable induction. Whatever your cocktail of choice is fine, but you just don't want to be chasing your tail later with hypotension. Inotropic support with norepi is almost guaranteed to be needed. I also have epi in the room. Avoid anything that increases your pulmonary vascular resistance, and then hypotension in general is very poorly tolerated in this patient population. They just don't tend to tolerate this. And so these patients, I often don't do propofol for with my inductions. Norepinephrine, again, is preferred for these patients. This is a table that came out of the pediatric critical care literature. I like it because it just shows what the causes of acute RV failure are, and unfortunately most of these are not things that we're going to avoid intraoperatively. So transfusions and boluses, positive pressure ventilation, acidosis, and hypoxia, these are all things that we deal with every day, and unfortunately if it's an emergent case and a patient who already has PAH, they're going to struggle, their RV is going to struggle. Moving on to pulmonary-wise, postoperative lung injury by definition is just anything that impairs oxygenation. It can be something as simple as bronchospasm and atelectasis. And most of the time we just give a little albuterol, 10 puffs, bag of it in, they're fine, or we just re-recruit and everybody's good and we think that we've done a great job and pat ourselves on the back. In actuality, these patients actually have a lot more complications and they're at higher risk of death. And so this is why our pediatric friends are much better at like, hey, if there's been any viral URI or respiratory ailments, we really need to push it back. I don't know about your surgeons, but mine are often like, oh, they're fine now. They don't need it. Really, this is why we want to wait and just kind of push things back. Ventilator-induced lung injury, unfortunately, is iatrogenic. It's something that we cause to the patient. And while it happens in diseased lungs, it actually happens more often or equally often in lungs that are normal. If your case goes on long enough or they're intubated inappropriately, setting-wise in the ICU long enough, it can and will progress to ARDS, which pathologically is just diffuse alveolar damage, and clinically it's just heterogeneous pulmonary edema, okay? By definition, it's acute, and so there's some sort of an inciting event, and it tends to be progressive. There's a pulmonary insult that can be direct or indirect, and the mortality is directly associated with the severity. And so your Berlin criteria, looking at your P to F ratio, or the PaO2 divided by the FiO2, is what we use to categorize mild, moderate, or severe. The ARDS-NET protocol, if you don't know it, if you're not familiar with it, is easy reading. It's like size 14 font and it's 1 page. It's literally easy reading. It's a protocol that was designed to help you with the initial ventilator setups and actually management for patients with ARDS to have a lung protective ventilation strategy. And it is regardless of what mode of ventilation you prefer. So if you are more of a pressure mode or more of a volume mode, it's irrelevant. It's whatever you like to pick. This is a copy of what the ARDS-NET protocol looks like. And drawing your attention down to the part 1, the ventilator setup and adjustment. The first thing is calculate the predicted body weight. It is gender specific, so biological males and females. And then under there, number 2 is select any ventilator mode. So you don't have to use a mode you're unfamiliar with or you're not comfortable with. The bottom right just shows you that based off of the plateau pressures, you can increase or decrease your tidal volumes, and if there's ventilator dysynchrony, it gives you tips about that as well. Often patients don't yet have arterial line to where we can get PaO2, and in those cases, you can actually use your pulse ox as a surrogate marker, okay? Ventilation goals, the ARDS, we want low tidal volume ventilation. We want plateau pressures lower, ideally less than 30. A pH that's somewhat normal. SATs 88 to 95 are perfectly fine. Actually, goal SATs of 88 to 90 are kind of where I target most of my patients. Clinically, that works out to be a PaO2 of about 55 to 80. So if you're getting an intra-op blood gas or your PaO2s or your SATs are running high 90s or your PaO2s are triple digits, they probably don't need the amount of FiO2 that you're on, or PEEP. Whatever you want to adjust is fine. Lastly, the concept of driving pressure may be something that not everyone is familiar with, but driving pressure, you want that to be low. It's actually an independent predictor of mortality. So separate from tidal volume, separate from plateau pressures, it's the difference between the plateau and the PEEP. The higher the driving pressure, the more likely your patient is to die. Moving on to GI considerations. Most of us know that the NPO guidelines we're familiar with were designed to lessen or to risk stratify the chances of aspiration in our healthy elective patients. That said, our ICU patients are anything but healthy and often anything but elective. And so because they're very catabolic and unfortunately malnourished, often iatrogenically, the ASA really sought to answer whether the question is as to whether or not these NPO guidelines are applicable to this patient population. And the answer is probably not. If your patient has a definitive airway with a trach tube that is cuffed or an ET tube that's presumably cuffed, and they're getting tube feeds, assuming that your patient's going to be in a supine position and your surgery is non-lung, non-airway, and non-luminal GI, you can actually continue tube feeds. Okay, again, clinical correlation advised. If your patient historically aspirates, if they've got gastroparesis or it's not something you're comfortable with, that's completely fine. My institution does not yet do this. Our ICU patients, we still do the regular outpatient stuff, and so we are working on changing that, and so I bring this to your attention. This is actually a copy from the ASA. This is showing both if your patient has a natural airway and something like a post-pyloric or Dobhoff tube, you can actually continue tube feeds 2 hours prior to the procedure, and you don't need to necessarily aspirate the tube feeds out. On the left-hand side, we show that if there is an airway, you can actually continue the tube feeds until the OR. And again, there's no large randomized prospective trials, but retrospectively, there's not been a trial showing that there's harm, and there's suggestion or the assumption that there's less harm, less ARDS, less mortality associated with it. Renal-wise, we talked a little bit about this earlier with hypotension and AKI. For all surgical patients, especially when we lump cardiac patients in, the risk of AKI postoperatively approaches almost 50%. Though there's different criteria, most people use the rifle criteria. The left side just shows you what rifle stands for. It's risk, injury, failure, loss, and E is end stage. It just looks at both their creatinine, their GFR, and their urine output. It's both sensitive and specific for the degree of AKI that they have. Again, like everything else, most of our risk factors are non-modifiable, but the things that we can directly impact include hypotension in the OR, anemia, and your choices of IV fluids. This is the same slide we saw earlier looking at hypotension. And with regards to AKI, we used to think, I say we because I was in this group, we used to think that people had an AKI, their creatinine bumped, urine output might have trailed off for a bit. Ultimately, creatinine normalizes, urine output picks back up, everything's great, they go home. What we now realize is that each episode of AKI actually has microscopic pathologic damage. There is sequela of each issue of AKI. If you have one bad episode of AKI that goes on long enough, or multiple issues of AKI, your patient can progress to end-stage renal disease and dialysis dependence. Anemia-wise, if your starting hemoglobin is less than 8 or you have a more than 4-gram hemoglobin drop, it's associated with post-op AKI. It does not mean that your patient needs to be transfused greater than 8 to go to the OR, but it means that you need to just be aware that if you're already starting with a hemoglobin of 7.3 and blood loss is a little more than you expect or your surgeon expects and they're getting soft, it may not be the fluid boluses they need as much as the volume from blood. Lastly, saline is independently associated with AKI because of the hyperchloremia and the metabolic acidosis. I do want to touch on sickle cell just because you may or may not be aware of a few things with the sickle cell patients. We know that they're at higher risk of complications. Acute chest syndrome is the one that I as an intensivist really worry about. The mortality is very high. And this table looks very similar to what we saw in our pulmonary hypertension, again, just showing that for things like cholecystectomies and appendectomies, they're at least moderate risk of death or perioperative complications. In this patient population, the first thing we should be asking is the surgery necessary? And I would say if this is going to be an elective, like a cosmetic surgery, the answer is no. Hard stop for me. They're just done. I'm really sorry. It may be chronic back pain and they need a breast reduction, but if they die post-operatively, I've not done them any favors. By that same token, if surgery is going to proceed, next you want to prepare blood, and you actually need to talk to your blood bank because you need blood that is specifically sickle negative. Sickle cell patients can be blood donors, and often they do donate. And so you need blood that is specifically sickle negative. You actually need it to be leuko-reduced, and you need to tell them you need an extended antigen panel. Your normal type in screens and type in cross is not going to be appropriate for this patient population. There needs to be a post-op care plan in place with your surgeon. And most of these people are going to be admitted for 23-hour OBS, especially anybody who's undergone general, which means more than likely they're not going to be appropriate for your ambulatory surgery centers. You need to talk to their hematologist and figure out what you're doing with their meds. And more importantly, what do you need to do as far as transfusions? Intraoperatively, the goal should be to really minimize vasoocclusion. You want to do everything you can to avoid increases in PVR. You want them to be warm and hydrated, really good pain control. And specifically, PACU, the use of incentive spirometer is associated with less acute chest syndrome. And so every patient needs an incentive spirometer. Not when they go to the floor, not when they're going home. It's in PACU as they're waking up. These people get transfusions repeatedly, and unfortunately, they're just prone to increased transfusion reactions. About 3 to 5% of the time they get a transfusion reaction, and of those, about 10% are going to be fatal. That said, anesthesiology guidelines, hematology guidelines came together, and the consensus right now is that for any general anesthetic lasting more than 1 hour, which for me at an academic center in July and August is pretty much all of my cases, these patients get transfused preoperatively. So you're not hanging blood after induction and before the timeout waiting on your chlorhexidine to dry. It is in pre-op before you time out and before you roll back to the OR. And so whether or not they get a simple transfusion versus a red cell exchange is really dependent on the patient. So you need to know what their starting hemoglobin is and what their phenotype and genotypes are. So are they hemoglobin SS or SC? And are they beta thalassemia or not? And again, talk to your hematologist. He or she is really going to drive this train. But this is why often outpatient ambulatory surgery centers, they're not appropriate. Glycemic control, we really want blood sugars 140 to 180. If you are more than 180 in the OR because of antibiotics or other drips, just start them on an insulin drip. It's just easier, they have better wound healing, and their mortality is decreased. Handing off to the ICU team should be done in person, ideally with a representative from each team. So somebody from the surgical side, nursing side, anesthesiology side. It does not have to be the attending themselves. In my institution, we have RTs that work in the OR as well. And so anybody who's intubated, our RTs go up with us and they actually hand off to the RTs upstairs as well. So in summary, for all surgical patients, mortality is about 1%, obviously higher in our ICU patients. Those patients that already have problems like LVADs, pulmonary hypertension, sickle cell, even the routine procedures for them, we're going to have to step up our game and do additional things to keep them safe. The goal is just to lessen any secondary injuries, and then handing off in person to your critical care team actually can lessen harm. Thank you.
Thank you so much, Dr. Iverson. I'm actually going to have our speakers come back up to the stage. We're going to start our panel discussion. In the meantime, if you have a question, please come up to the microphone, or wait, where are the microphones? They're happy you don't have questions. Dr. Iverson, you had, I'll go ahead and start. You had mentioned the use of norepinephrine norepinephrine as to help RV contractility. What about the role of nitric oxide? Do you commonly use that? And then I think there's like iloprost, or yes.
So we don't use nitrous very much, and certainly not in the OR. We do use epoprostenol, or Velitri is the trade name. I use it more in the ICU. We do use it in our heart patients in our cardiac rooms. I am not a cardiac anesthesiologist, so I get them on the back end. If I have a patient who I think is going to struggle from an RV standpoint, then yes, I actually we'll move them in, or we do the cases in those rooms. And then, like I said, we are fortunate enough to have RTs in my ORs, and so they will set up, and I will just order 20,000 of Velitri or epoprostenol, and I just run it in if I need to, intraoperatively.
Okay, thank you. Jason and Jonah, thank you so much for that history. I'm going to ask you, because we're so excited about your interest in osteopathy, and I'm sure you've learned a lot from Jason. What was like a good takeaway that you learned as you were researching the history of osteopathy?
Hello. Thank you. I think one of my big takeaways is, I know a lot of times people will say, like, if you don't learn your history, you're going to repeat it. I think that has kind of like a negative connotation. I think this is a really fun story because it shows a time that you can look back on history and look at everything that came together to create really osteopathy, and all these like tiny little pieces that kind of, all wind together. But it's a very positive spin on, look back at history and learn from it and grow from it.
And you've got a great mentor. I feel like Jason was side by side with A.T. Still all these years, because he tells this great, colorful story. So I really appreciate that. Dr. Grenda, I'm just bouncing around, as if anybody has any questions, please come. But Dr. Grenda, for these patients that have these risk factors, prolonged intubation, diabetes you had mentioned was a risk factor as well for posterior glottic stenosis. Is it your practice to do like an awake look first if they have like that the respiratory distress or the just like the physical signs and symptoms of respiratory distress?
Yeah, that's a great question. There's actually been a lot of literature, particularly coming out of Yale. There's an anesthesiologist there that's very well versed in preoperative assessment of or airway assessment, and he actually performs and has written a lot on preoperative endoscopic exams in the preoperative area. I do not do it on a regular basis, but I more so just related to resources and time. But maybe I should potentially reevaluate that and incorporate it into my practice. It's probably not realistic for everybody, but if I'm actually concerned about it and I feel confident enough that I would have to put a pause on the procedure until I have further knowledge about the patient, I would advocate for it, yeah. And it's relatively easy in most institutions, even if you have like the disposable stores or Ambu that this plugs into the glide scope scope.
Yeah, I think that your patients are probably more cooperative than mine. So
I would say so. Yeah.
So I like when our ENT surgeons come up to us and say, we want to take an awake look. And I'm like, on this 3-kilo baby, sure. Yeah. So, it's a concert of medication and, work between all the people in the OR. So I often think that, I think we get valuable information from it, and certainly in your patient population or the ones that you see with the head neck surgery histories, radiation, that might be something
Yeah, and more often than not, the patients have already had some degree of scoping in the office. Mm-hmm. So I just explain, hey, it's going to be similar to this. We'll try to get you as comfortable as we possibly can. Most patients are complying with it, to be honest with you.
Also, you had mentioned that the patients, you typically do extubate after a surgical intervention for their airway. What percentage of those patients do you feel safe about, like extubating and going to the ICU, and then perhaps like not needing airway intervention afterwards? Or is it like taboo not to extubate because they have that risk of the stenosis and they've had that history of it?
No, and again, that's another good question. I think usually following the procedures, assuming I'm fortunate enough that the surgeons that I work with, I trust their opinion, and if they feel that, hey, the airway looks patent, they usually show me, that's why I always say, like, make sure that we have an emergence plan, and typically it is to go to the PACU. It's not directly to the ICU, unless it's a slightly larger procedure, more involved, such as the gentleman that we took care of in that situation. But more often than not, I've done hundreds of these. We usually bring them to the PACU, and it's, patients tolerate it relatively well.
What about the percentage of restenosis?
Restenosis, that, again, it's variable, and it depends on the etaology. The idiopathic, it's quite high, and these patients come from serial dilations every couple of months. As we move forward in medicine and procedures become more and more specialized and complex, only time will tell. But with regards to the more invasive procedures, I'm not talking dilations, but I'm actually talking about like the chordotomies and resections. Again, I mentioned they were more definitive procedures, but there still is an incidence of restenosis.
Thank you. Jason, as you just have such a wealth of knowledge, what would you impart? What would you impart on our audience about trying to keep that, the drive to understand and keep that history rich? What would you impart?
Well, thank you. And again, I appreciate being back again. I do want to explain what happened earlier. Our clickers in both rooms were on the same channel. So I was messing them up as much as they were messing me up. So it was just like, basically one body, two spirits. It doesn't work. So at least now you understand. And there's we fixed it. And I give you guys a lot of crap because anesthesiologists, whenever I have to do like a video for you guys, and I'll record like 45 minutes of straight talking, and then they'll say, okay, we reviewed it, and you clear your throat about 30 minutes in. Would you like to redo the video? And it's like, no. Would you like to edit that part out? It's like, no, people clear their throats when they talk. I was like, you guys, you just are so anal, you repeat, and then we would do the introduction. And you know, hi, I'm Jason Haxton, and we'll go to the video. And they say, okay, tomorrow, would you like to do this again? It's like, do what? It's like, introduce yourself to the video. It's like, say, hi, I'm Jason Haxton, here's the video. Yeah, would you like to do that again tomorrow? And like, no. So I always give you guys, because you guys are so, now I realize why. Today is a good example of why you practice and get it right. So I give you that. But what I'm saying is Dr. Still was an amazing person. He didn't want to be a physician. He just wanted to be a farmer. And then Missouri weather destroyed that opportunity. He wanted to teach. It didn't pay. Medicine was his third option because he had to get survival. But then he get into medicine and he got his education, said this doesn't work. And it's being honest. So we have a mentor that has no skeletons in his closets except for skeletons that he used because he understood we're all on this spiritual journey of learning and loving. And that's what he got towards it. He goes, we should love everybody and we should learn. And we take that with us at the end. And so that's why he left enough room with osteopathy. He always left a space so that people like Jonah and you would learn and make it yours and you would take it further. So I think the more we learned about Dr. Still, part of why he looked so simple was because he wasn't into, basically the appearances or the educational mannerisms stuff. He was just an honest guy and did what was simplest. And so in that, we have a mentor we can be thankful for. And it's no wonder that one guy with an idea is now 25% of the medical profession. You got to be doing something right. And that's your heritage. So again, we keep the history. It's growing. And we're always here to help you learn more about what's going on. So thank you.
Thank you. I'll also add that he has a table, there's a table outside where he has some artifacts that he's going to share with all of us. So
we have an exhibit of all kinds of things. You guys actually read the stuff. So there's actually a table of fun history and things about the early years, the real stuff. And come on out. I'll be here through Tuesday to look at it.
Thank you. Dr. Iverson, is there anything on the horizon for advancements in pulmonary hypertension patients, like stem cell therapy, and where are we with that?
Sorry, thank you. I'm not aware of there being anything from the stem cell research. There's now 5 classes of pH drugs, 5 different classes, with the 5th class being a new agent that actually just got FDA approval a couple months ago. So there's always advances. Mm-hmm. Ultimately, depending on the age of the patient and other comorbidities, especially for group 1, pulmonary arterial hypertension, heart-lung transplant is ultimately the definitive therapy right now. A lot of it is really controlling what the underlying disease is. So revascularizing if it's due to ischemic heart disease or, not using illicit drug use if, that's the cause, controlling or alleviating things like your chronic hypoxemia. So I am not aware of anything from a stem cell transplant, but I do know that there is now a 5th new class that was created. So there are more drugs, I'm sure, coming down the pipeline.
Awesome. Thank you so much. In terms of the patients that come to the OR with an LVAD, at your institution, do your cardiac colleagues care for those patients, or is it?
Yeah, so we actually, in my hospital, we're academic, and so I have a cardiac team and general team. We're a little bit specialized. However, our LVAD patients are honestly not considered to be any different than anyone else. And so, though my cardiac partners do rotate and do general call and do general cases, they're not necessarily given an LVAD because it's an LVAD. And so in our endoscopy suite, in our GI suite, it's usually CRNAs that we oversee. And so the LVAD patients themselves are taken care of predominantly by the generalist unless there's a cardiac indication for them to need it, which really we define as needing a cardiac surgeon, then they're just bread and butter. You know, if they're coming in, unfortunately, if they're coming in for an X-flap or, you know, a total knee or, you know, whatever. Yeah.
Wow.
Yes, yeah.
Wow. That would give me palpitations.
Yeah, and to be fair, I mean, a lot of my generalist partners aren't comfortable with it, which is why when I was making this talk, I said, you know, give me the patient populations that you would want to know about. So, you know, I got this, oh yeah, talk about LVADs. Oh yeah, talk about pulmonary hypertension. Oh yeah, sickle cell, you know. Because, you know, I get palpitations when I think about a 3-kilo baby.
I love that.
Yeah, but
I love them.
yes.
But yeah, no, I think that's important to know because, as you said, just by virtue of having the LVAD, they've got risk factors for GI bleed because of the anticoagulation that they're on, and so can certainly, I mean, usually you might not have the time to find the person who is the most comfortable taking care of the patient.
Correct.
But do they still go under, I would assume that they still have the same evaluation that you would for any cardiac patient, right? Like, would you, I guess they're usually coming in for something more emergent, but like for an elective procedure, like you had mentioned, cholecystectomy or
Yeah, so if they're coming in for like a routine procedure, like a lap chole, lap appy, you know, even a joint, you know, just like with any other thing, the first thing we do is go back and review records from their cardiologist. My institution, because we do heart transplants, we're very familiar with LVADs, and so we actually, instead of having the patients wear their own batteries, each battery lasts about 6 hours, and they always have 2. The patients are actually discharged home with extra batteries as well. But there's actually a cable that you can connect in and just connect to wall power. We have tablets that are literally iPads that the LVAD company, the OMS-III company, partnered with iPads that just displays our settings for us. And so, you know, we can sit over there and, you know, take care of the patient. And then from 10 feet away, I can see what their PI is, their power, all that. You know, we review the records like we would for anyone else. But as long as they've been stable on their current settings, there's not really a whole lot else that needs to be done. Now, we do get their cardiologists involved because they are fully anticoagulated. Again, you know, often these patients, you can't necessarily stop their Coumadin. And so we will sometimes, the surgeons will coordinate with our heart failure cardiologist. They'll bring them in, just put them on a heparin drip, or just reverse briefly and then, you know, perioperatively hold their anticoagulation. We are mindful for our total joints that they're going to be anticoagulated. They've been anticoagulated, so neuraxial is often not available for them. And if it's something like a total joint, we try to send them through our pre-op clinic, and we just have discussions with them. We're very honest. Everything is a risk and a benefit. But honestly, by the time they've gotten their LVAD, they're pretty familiar with the risks of surgery. So yeah.
Thank you. Hopefully they don't have someone next to them that can crosstalk with their programming, just like our our clickers today. But if there aren't any questions from the audience, we are at time. So if you would just help show your appreciation for Dr. Grenda, Dr. Iverson, Jason, and Jonah today. Thank you so much for joining us and sharing your expertise.